A very good morning to all. I will be presenting the role of fundus fluorescein angiography in diagnosing and treating the various macular disorders. Now, the fundus fluorescein angiography, the abnormal fluorescence consists of either hypofluorescence, which may be due to blocked or due to vascular filling defect, or hyperfluorescence, which may be due to leak or staining. Now, in hyperfluorescence, the leak, both the size and intensity increases. If it is pooling, the size remains the same, only the intensity increases. And in window defects, the size remains exactly the same, intensity increases a little. And staining, both the size and intensity, it remains the more or less same. Now, the various macular pathologies, it may be either may be due to CNVM or CSR, diabetic retinopathy, or various vascular occlusions, inflammatory causes, neoplastic or miscellaneous. Now, coming to the very important disease of CNVM. The classic CNVM, the abnormal fluorescein, it shows a lacy pattern of hyperfluorescence in early pattern, in early phase with leak, which increases with time, and the surrounding areas of blocked fluorescence is due to the presence of subretinal hemorrhage. In occult CNVM, the early phase, there may be stipple pinpoint hyperfluorescence or the late leakage of undetermined source. In staining, we can see if there is presence of only Drusen, then there will be only staining. In pooling due to the RPED, there will be hyperfluorescence, only the intensity will increase, but no increase in size. Now, coming to the indications in various AMD disorders, the angiography has to be done in unexplained visual loss, symptomatic patients, and suspected CNVM, or neovascular AMD, or post-treatment of neovascular AMD for studying the course of the disease, or we have to decide the course of retreatment based on the angiography sometimes. Now, in POLYP, this is the right eye has a vision of 6/6 and the other eye has a macular scar. Now, if we see carefully, we can see our orangish vision. If we do the angiography, there is a patchy hyperfluorescence which increases in late phase. But for proper diagnosis, we need the ICG, which will be discussed later on. This is the case of IPCV. We can see this huge subretinal hemorrhage, which a point of patchy hyperfluorescence. But for proper diagnosis of IPCV, the ICG is required. Now coming to the CSR, the ink blot leak is the most common pattern, which increases from the early phase and increases and the leak increases with time. The smokestack pattern is due to the fibrin-rich SRF. And in the chronic CSR or CRP syndrome, there are atrophic tracts which will manifest as window defects. Now, after laser photocoagulation, we can see the pre-treatment angiography. There is a profound leak. In the post-treatment, the leak has gone. Now, in parafoveal telangiectasia, there are multiple pinpoint leak temporal to the fovea, increasing with time. It is helpful to detect CNVM, and associated with this, OCT has to be done. Now, coming to retinal leak in CME, early venous phase, there may not be leak, but in the late phase, there is a typical petaloid leak. And for this leak to appear, we need to do the angiography till at least 8 to 10 minutes. Now, the aim of FFA in diabetic retinopathy and various vascular occlusions is to detect the extent and areas of capillary non-perfusion, ischemic maculopathy, and to diagnose whether the macular edema is focal or diffuse, because the treatment differs in both. Now, in diabetic retinopathy, in this patient, we can see the phase is grossly distorted with NVD, with leak in the region of the disc and peripheral CMP areas. And focal was a diffuse leak. In focal leak, we can see focal areas of leak. And in diffuse leak, there is a generalized RP dysfunction and generalized leakage from the entire capillary bed. Because the treatment in focal leak, we have to go for laser, but in diffuse leak, only treatment is pharmacotherapy, followed by laser. Now, in clinically significant macular edema, there is a pre-laser angiography. We can see the leakage, and post-laser, the leakage has gone. Now, what are the various indications of FFA in diabetic retinopathy? Most important, mild to moderate NPDR with CSME, or severe to very severe NPDR with CSME. High risk PDR with CSME. But for follow-up, it may be required, may not be required. It varies from physician to physician. Now, in BRVO, this BRVO, it is outside the macula. The macula is absolutely healthy. But in macular BRVO, we can see in early to mid phase, there is a mid dilatation of the occluded macular vein, blocked fluorescence due to the hemorrhage, and widening of the intercapillary spaces superior nasal to the foveal avascular zone. And the late phase shows the typical leak and the angiographic cystoid macular edema. In CRVO, in the acute phases, it has done mainly for academic purpose. In acute phases, it is usually not done because all the information will be hidden by the severe retinal hemorrhages. But in ischemic maculopathy, it is very important because the prognosis, it depends on the angiography, because we can see the phase is entirely distorted. So the visual prognosis is guarded in these cases, and there are controversies whether anti-VEGF should be used in ischemic maculopathy or not. Now, coming to BRO, we can see in the early phases, the artery, this is not filling. So the early phases has to be captured when we are suspecting any case of BRO. In late phase, the artery is filling, but in the early phase, there is a late filling of the retinal artery. And this patient is a case of CRO, but cilioretinal artery is spared. So we can see the cilioretinal artery being perfused very well, but the periphery is filling very late. Now, in retinal artery macroaneurysm, we can see a fusiform dilated area of the retinal artery, which is giving rise to this subretinal and subhilar hemorrhage. Because in RAM cases, we can get hemorrhage in all the planes. It may be subretinal, intraretinal, and preretinal. So we can see if we are suspecting a RAM, angiography is very needed, because then we can see the fusiform dilated area of the artery. Now, coming to some inflammatory disorders. This is 18-year-old male with blurring of vision both eyes since 1 week. In right eye, the BCVA is 624, left eye 618. We are doing the angiography. In the early phase, we can see there are multiple pinpoint leaks in the superior to the fovea. In later phases, the pinpoint leaks are becoming more prominent, and it has appeared in the other eye also. And associated with some pooling in the macular region. And this is one more similar disease of APMPP. This is a 22-year-old male with blurred vision both eyes since 5 days. In angiography, in all inflammatory diseases, there is initial hypofluorescence due to the retinal edema. And late phase, there is an increase in pooling and leakage. Pooling in the neurosensory detachment due to the presence of fluid, and leakage, early hypofluorescence followed by late hyperfluorescence. Similarly, in posterior scleritis, we can see the typical T sign, and there is a choroidal folds, and there are pinpoint leaks with pooling in the inferior area where there is an exudative RD. So we can see the pinpoint leaks with inferior pooling. In GHPC, we can see the areas of leakage along the edges of the lesion, which is indicating activity. So in the fundus photo, it may appear to be an innocuous lesion, but if you're doing angiography, we can see the leakage along the edges. So treatment is needed. And this is a rare case of 56-year-old male who is complaining of diminution of vision with vitritis and creamy-colored lesion deep to the retina in the superior quadrant. And the macula is looking quite okay, but when we're doing angiography, we can see the punctate hyperfluorescent window defects and round hyperfluorescent lesions which are corresponding to lesion. So this angiography is very classical of intraocular lymphoma.